All right, we'll go ahead and get started. I'd like to welcome everybody to the Mid-Atlantic Telehealth Resource Center Conference in Charlotte, North Carolina. I do really wish I could be there in person with some of y'all, as that's my home state. So I hope that you all are enjoying the conference and your time there. Just to let everybody know, this session is sustaining virtual care for people with substance disorders. So if that's the session you're looking for, you're in the right place. If you're looking for another session, take another look at your agenda, and I'm sure there's some people that can help direct you to the other room you'd like to be in. So I'd like to thank both our in-person and our online audience for joining this session. We have two speakers this afternoon with us for this session. We have Steve North, who is the Vice President of Medical Operations for Eleanor Health. And then we have Zachary Jensen, who is the CEO of Aspire 365. For this session, we are going to do a very panel moderated question style, and then also be able to have some time for some questions for the audience. So we know that it's probably been a long day during the day, and so just really want to be able to have the comfort of discussion and making sure that our speakers really their intent is to make sure that they're addressing the information you all would like to hear and learn about. All right, so I am going to turn it over to Steve first, just to give a bit of background and information on his organization. Then we'll hear from Zachary, and then we'll get into the questions.
Great, thanks, Whitney. I'm Steve North, and as Whitney said, I'm the Vice President of Medical Operations for Eleanor Health. Eleanor is a relatively new organization in the substance use disorder treatment space. We've been around for 2.5 years, opened our first practice about 25 miles away from here in Mooresville, North Carolina in September of 2019. And since then, we've grown to just under 30 practices in 6 states across the country. We have 11 practices here in North Carolina. In September of 2019, we opened in Mooresville. We added 4 practices in North Carolina, and then the pandemic hit. And so while we had been using some degree of virtual care and it was on our roadmap, we all of a sudden moved very quickly into providing, right now, about 90% of our care is provided entirely virtually. So Eleanor is a practice focused on whole person care. We provide psychiatric services, substance use disorder treatment services, therapy, and peer coaching through what we call community recovery partners, as well as nurse care management for patients. We call them community members. We envision people, and we treat all substance use disorders, not just opioid use disorder. We envision people coming to Eleanor and being part of our program for 3 to 5 years, and recognize that harm reduction is the evidence-based way to provide care for people with substance use disorders. So we want to treat what is first and foremost on that person's mind. We do not adhere to an abstinence-only model saying, well, you also have to stop smoking cigarettes or drinking alcohol while we treat your methamphetamine use disorder. And so that's sort of the clinical side. On the other side, we are really invested in data and outcomes and trying to demonstrate that our model of care works well. So we track ED utilization and inpatient utilization. We've been able to demonstrate that since our inception, comparing the first 90 days the person comes to Eleanor versus the 90 days after, we see a 43% reduction in ED utilization. We look at improvements in PHQ-9 and GAD-7, and also the substance craving scale to measure the impact on the substance use disorder and mental health. Looking at clinically significant improvements of 5 points or more, a reduction in those scales, not just statistically, oh, you went down by 5%. And we also track what's called the Recovery Capital Scale. And the Recovery Capital Scale is a tool that's been around since 2008 that looks at the impact of 35 items that are tied closely to social determinants of health, that as your strength in each of those items improves, your likelihood of staying in recovery improves. And so we administer that every 90 days to say, if somebody's coming to Eleanor, their urine drug screens are consistent with their goals of care. However, their recovery capital scale is not improving. It's great that they continue to see us, but what additional services do we need to wrap around to address housing insecurity, employment, education? And we are, the other part, what makes Eleanor a little bit different than some of the entities currently in the virtual care space, is that we're really working on relationships with insurers. While we do fee-for-service care and bill insurers directly, we are building a group of population health, the patients who are referred to us by their insurer with a high likelihood of substance use disorder, and we reach out to them to try and engage them not in substance use disorder care, but in partnership to improve their overall health. And if they identify a need for SUD care, we'll provide that. If they identify a need for therapy, we can also provide that. And or just psychiatry, connect them with primary care things. So that I'll turn it over to you and tell us about it.
So I'm Zach with Aspire 365. We deliver structured programming for substance use disorders and co-occurring behavioral health conditions. We deliver services through kind of a unique structure where we send certain providers into the residence to work with patients directly in home, as well as through telemedicine. During the pandemic, it gave us a great opportunity to kind of test the role of pure telemedicine services and its capabilities and reach at a high level, which was great. But our general structure delivers services to the patient through that combination of some in-person, some telemedicine. We deliver services to each patient. As I mentioned, it's a structured program. It's a 12-month baseline program that can be extended based on patient need. And that baseline program is delivered through a combination of 6 providers. The providers include an addiction psychiatrist, a nurse or nurse practitioner, an individual therapist, a family therapist, a case manager, and a peer recovery coach. We work with adolescents and adults, 12 years old on up, and we treat all substances. We're tracking many of the same metrics that Steve mentioned to determine effectiveness of the program and outcomes. How are we reducing clinical spend for patients that do not need clinical spend? What are the tracking of the assessments and how are they improving through the program? Those are the key indicators that we're looking at. As I mentioned, we work our program around patient schedules, which is how the structure is designed, so they get high-level chronic services around their schedule, around their work and family life, so they can get services where and when they're.
Great, thank you. Appreciate both of you all for your introduction and just some background information about your organizations. So the first question that I would like to pose and get y'all's feedback on is, what role have you seen really technology play in the integration of substance use disorder into virtual care?
I think that for us, I can jump in.
Please.
I think that for us, it is beyond just the video visit. What have we been able to do with technology to really engage our community members? And I am fortunate to work for a company that's got resources to develop our own, what we call Ops Hub, which is a parallel EHR, basically, to our standard EHR, bi-directional sharing of information. And we have the ability to push scales to our community members, push a free chat, open chat line to them, and engage them not just with an in-person visit or a virtual visit, but also in between to have scales completed, have them engage us in a brief conversation about how they're doing, check in on medication side effects. And the more people use that aspect of our care, we find the higher level of retention in care.
I think for us, we've seen kind of this real capability in recent years with the reduction in size of medical devices and the cost effectiveness of certain technology to allow us to actually make certain medicine convenient. I mean, I think we all have this vision of the doctor with the brown leather handbag going to the home. And when you're sick or not feeling well, that'd be really nice. And telemedicine has expanded that. But for us, over the last year, we've been able to beta test a number of different programs and products to deliver, as I mentioned, services such as nursing entirely via telemedicine. It not only allows us to check on vitals and do toxicology screens and know how the patient is doing physically through a telemedicine call, but it also allows us to deliver those services like immediately, right? Where we generally, patients have to wait to go see a psychiatrist. They have to wait to schedule an appointment with a doctor to get in and see a nurse or have that doctor's visit. We've been able to really enhance how quickly we're able to get a psychiatric evaluation done and get a nursing assessment done. And on top of that, we've really been able to expand who we've been able to reach. I think the rural communities, the critical access areas who are generally underserviced can take advantage of services now because we can get services there, high level professional services where rural communities are not going to have addiction medicine services from addiction psychiatrists. We can get top tier professionals to hard to reach areas through new technology, which is really, really cool. And it's made everything very, very flexible and accessible and convenient, right? Which is what we're going for. And on top of that, cost effective.
And would either of you like to talk a bit about the accessibility when it comes to these services and technology for some of the rural communities?
Yeah, I live in a town of 1,800 people in the mountains of western North Carolina. So I live in a rural community where I practiced at a rural health center for 15 years before coming to Eleanor. And the ability to reach people in their homes or on their job site is changing the frequency of engagement and opening up services to people that clearly would not have had services before. We are, without virtual care, there are big swaths of North Carolina it's a rural state. And we're in, Eleanor's in 6 states. And so, another rural state that we work in is Washington. And once you get across the Cascade Mountains, there's very little access to specialty care, or really once you get outside of Puget Sound until you hit Spokane. And so we have maps that show that we're hitting people in every part of the state. So in North Carolina, all the way from the Outer Banks, Hyde County, to Murphy, North Carolina, which is the far southwestern part of the state. And the convenience of access is keeping people more engaged. If you don't have to drive an hour to see the doctor for 15 minutes to have a prescription written or to see your therapist, really changes your level of engagement. And also the fact that the organization is able to flex and provide those services to you on your schedule makes you feel more, our community members tell us they feel more connected. Yeah.
I think those high level measures of success when you're looking at like a whole patient include are they actively engaged in the community? Are they working? Are they doing these things? And centralized services inhibit those productive key factors when you're looking at the success of a program. And so when we're talking about being able to deliver services, convenient services to individuals who need them, we can dramatically improve success, engagement. They have resources, they have access to providers, they have communication tools, they can see providers interim between appointments, which is huge. And it's cost effective, it's time effective, and then it really starts to tear away at those borders, some of those barriers to getting treatment. One of the biggest barriers is people just can't leave their lives. You know, you go to rural communities and rural communities, and you're going to know this better than I, there can be a lot of stigma in smaller rural communities, and when we're engaging with patients in rural communities, it has to be convenient. It has to be somewhat discreet. It has to be, you know, where they live, how they function, because they're not going to leave to get service. And we know a high percentage of patients or individuals that need help won't get it. We're talking like 80% of patients won't go get help because it's not convenient. It's not what they feel accessible. And yeah, so the technology, telehealth, and all these resources are really helping remove a lot of those barriers.
But I think you brought up a great point, Zach, that it's not just the technology, it's the stigma.
Yeah,
And that's, you know, we hear from community members on a regular basis that organizations that may provide Suboxone or may provide methadone, which Eleanor does not because of regulations around OTPs, but there are organizations that, yes, will treat that, but it's in a stigma-filled environment where they're not looking at a substance use disorder as a chronic disease. They're looking at it as a moral failing, and you have to stay clean, and your urine is dirty, and sort of negative words like that that push people away, or they just are trying everything they can to stay in recovery because of fear of messing up and getting kicked out of the program.
Yeah. People are going to be much better served if they're not having to get help after a massive adverse event. They're not having to come get treatment after going to the hospital from an overdose, right? I mean, the more mainstream, I guess, we can take, certainly addiction medicine, which has been a serious outlier in the medical field, and wrap it into traditional medical services and start delivering some successes, which will help unfold it into traditional medicine, and start utilizing these tools and make it more accessible, more convenient, remove some of that stigma. We can start looking at preventative measures, right? And we can start looking at how we intervene and how we get patients or individuals help before we have significant adverse events and they're coming to us from, you know, the traumatic filled experiences, right?
Great, thank you for that. And so we talked about technology and stigma as some of the challenges. Are there any other challenges that you found specifically with virtual care and substance use disorders that you'd like to speak about?
Regulations. That's that's a big pain in the butt. I mean, COVID was awesome because we got some removal of the limitations that will stop providers from getting services where services are needed. The ease of licensure, at least even temporarily, the ease at which psychiatrists can get in there virtually and deliver care and prescribe without an in-person visit. Some of those barriers, the removal of those were really, really effective. And we're seeing some of the clawback on those measures, right? You know, for different reasons. But the removal of some of those barriers was very helpful in being able to expand these processes and procedures and get services where they're needed. So hopefully, you know, it starts to move that direction. We're seeing like the counseling compact, which looks very promising, and things like that, where we're going to start taking strides. And now that we've seen a lot of the effectiveness of the data from telehealth and the tools that are at our disposal, but ultimately, it's, you know, that'll take some time. But regulation is a big barrier for sure.
I think that one of the challenges we face, and we're working to resolve it, but a year ago, we had a surge in demand and a provider shortage. And that resulted in a provider affiliated with our Hickory clinic seeing somebody for care who was also seeing the therapist from the Wilmington clinic virtually, and their nursing care was being provided by somebody from our Durham clinic. And it was piecemeal in a way because there wasn't a solid treatment team for people to talk about that individual. And how do we do a better job in a virtual environment where you're delivering both in-person care and asynchronous care make sure that you have a treatment team that still talks to each other. And the stuff that comes out in a treatment team meeting and the information shared is very different than what actually makes it into the chart. I can tell you stories about my, patients, and most providers of any color can, of any fabric can, that don't fit in the chart in a neat, simple way. And so that has been lost as well, and trying to regain that in a way and encourage more communication. Another thing that happens is that Zach and I are sharing sharing care of somebody, and in the moment, I send a snippy internal text to Zach, like, why didn't you do this? And he's like, well, Steve's a jerk, I'm not gonna talk to him again. I don't have the ability to later that afternoon say, how are the kids, or what'd you think of the game last night? We lose that sort of water cooler talk, lunchroom talk. And how do you, as a leader, make sure that you're keeping your team together and think about that aspect?
Yeah, the coordination effort from like a national level, as you start to look at like the hub and spoke models, and we've implemented some of that and had good experience, but a lot of the structural difficulties is how do you coordinate these services, among clinicians, among providers? How are you making sure that the communication isn't just concise for notes and not translating the whole picture of the patient for each of the providers, right? If you're going to provide holistic support and really engage around the patient, how does that coordination happen? So I think a lot of that comes to like the development of EMRs and software systems and some internal workings. I mean, these things are still being developed and improved upon, and will continue to be so. But yeah, those are additional difficulties for sure, is making sure that the providers are communicating at a high level and still getting that level of engagement, even though they're not sitting in the same office, right? Utilizing telehealth in an effective way so they can talk.
I think another challenge is so many different, multiple platforms and managing of data that on both the community member side, well, where's my link? So early on, we were sending a separate Zoom link for, in a single day, a therapy visit, a nursing visit, and a medical visit. And people got confused. I would get confused. So finding a software solution that let us send a single Zoom link for that, a unique Zoom link for that community member for the entire day is a simple fix, but that was a pretty big challenge for us. The one question that comes up the most in the virtual environment from some medical providers, as we describe our model, is, well, what about the urine drug screen? Because that is, that's really what many providers treat to, is the urine drug screen, as opposed to treating to the community member that's there in front of them. We use urine drug screens, and we use a CLIA-waived screen that we either have the community member come in and pick up, so in the office, for urine drug screens a month, and if needed, and we will then have them show us the closed container in the package, go away, leaving their phone on the kitchen counter. We do not want to go to the restroom with them while they provide the specimen, and then coming back and reading it online with them. And yes, there's the opportunity for misuse, but once you establish a relationship with someone where you're really not, you help them understand that you're not going to kick them out of care, that you're going to keep them in care even if they resume use, that breaking down that barrier and then asking them even before the urine drug screen, what will be in your urine drug screen today? And only addressing inconsistencies as opposed to, really drilling down. Some organizations sent everything. There's an entity in Massachusetts that's a national organization that got sued by Medicaid in Massachusetts because they were using 14-panel confirmatory tests every time people came in at $600 a pop. And if you own the lab, it becomes very lucrative to do. And we set the threshold that we will, if there's an inconsistency that we disagree on in the urine drug screen between the community member and the provider, we'll send it for confirmatory testing. But we're not using this as a punitive measure. It's an educational measure. And one of the nice things is we can do fentanyl tests. Well, there are no CLIA-waived fentanyl tests, but we can mail fentanyl test strips to our community members to use at home that we couldn't use in the office because there's not a CLIA-waived version, meaning it's against regulations to use that test, which is an irony. Yeah.
Yeah, really, on that note,
Yeah.
all we need is a saliva screen
Yep.
that's going to detect 100 days back
Mhm.
and be very accurate and give us all the answers. That's all we want. And for $5. If we could just do that.
If we could do that, that would be ideal. We hope to move to saliva, but it's not CLIA-waived, but yet there's some opportunities out there. We can talk about that
Yeah.
afterwards. Yes. Yeah.
All right, great. I'm going to ask one more question and then we'll be able to open it up to some questions for the audience. If you do have a question and you're joining us online, you can use the chat in the Zoom or the event Mobi. And then Stephen, Zach, and me calling you to just help with some audience questions there in person. My next question is if you all could share just maybe one best practice that you've really learned in doing virtual care or best practice model that you found very helpful in doing virtual care for people with substance disorders.
For us, one of the best practices was having a system in place for communication from the patient to treatment team. Setting up those lines of communication it's extremely helpful during that initial stabilization phase, that initial 2-3 months where patients are still stabilizing. And during that time, having a communication system in place where they can reach out in an easy fashion to their case manager or their therapist, right, and communicate concern and need between regularly scheduled visits has been proved incredibly helpful. We found that patients will generally reach out when they need something and bring it to our provider's attention, because most people, when something is going wrong, if something isn't going right, they're not certain as to what to do about it. And having an immediate point of contact where they know if I reach out, someone I'm connecting with will know what to do is very, very powerful. And we've seen that in and of itself really drop emergency department utilization, because we're able to step in and intervene when a patient would otherwise go to an emergency department and they really don't have to, right? We can help them, we can connect them with primary care physician, all of them. So yeah, that has been a best practice for sure.
I think one of the things we found is that if someone doesn't show up to their visit, which if I was in a traditional practice, I'd say, oh, they no-showed, I can't do anything about it, they're not going to make it here. Pick up the phone and call them. They may have forgotten. They may have, been delayed, and try to make sure that they stay engaged in care, and you can either see them then or get them rescheduled. But putting that challenge to the medical providers, in particular, the therapists as well, to pick up the phone and call is a new thing for many people. That demonstrating that you care, that you want to be engaged in care is important. Helps long term.
Yeah, disappointments are, especially when dealing with patients with substance use disorder, is a big red flag.
Yeah.
And so, yeah, getting in touch with them, having the emergency protocols in place, people to contact in addition to the patient and get the information for, it is a game changer for sure. Yeah.
All right, great. So I think a good way to be able to do this is I'll ask one of the questions that we have online, and if you all can answer, then we'll open to the in-person audience, take a question. We can go back and forth that way until we're out of time. So our first question online is there any remote patient monitoring included in either organization's virtual program? If so, what and how?
For us, yes. We do We use a couple of different devices. And again, it's great to come to the conference and see what other devices are available because we tested them out. But our patients head to the program and they get FedEx an onboard medical kit. And the medical kit includes a pulse oximeter or breathalyzer, a sleep monitor, which generally we're tracking for insomnia using either a sleep pad or like a Fitbit. We've used a couple of different devices and it varies depending on the patient appetite, right, for what they want to use. But those areas, we'd love, like, anybody that knows like a real-time device will give us heart rate and blood pressure and the battery lasts 60 days. That's all we need. But yeah, I think, the technology itself is definitely improving and we're able to get, a lot of really good patient metrics from the devices that we're currently using. And that's just going to expand in the future.
We are not using any RPM technology today. We have been discussing it and are trying to find the best use cases for our community members. And what is it that having RPM data, whether it be weight or pulse ox, would change the care trajectory? As we have moved into population health, there's a clear benefit there as we look at total cost of care and engagement with primary care. The question is, should Eleanor and our nurse care managers be providing the remote patient monitoring, or should that be handled by primary care practice or cardiologist, someone else? So I think that if we identify a use case, we definitely want to explore it. I'm more interested in digital therapeutics and how we can use those in our practices.
Great, thank you. Do we have a question from the audience? If you'll raise your hand, maybe Steve or Zach can help to identify.
Yeah.
Well, since I know a lot about Eleanor, I'll direct my question to Zach. I'm curious about the scalability of your program, like the size, but also scalability. Is it something to be replicated, or are you poised to grow?
Yeah, so we've been around for about 3.5 years. We've been treating patients for a little over a year now. That's right, we've got a 12-month program, and we're just having our initial patients complete the program, right? And so far, so good. But the scalability part, we've expanded ever since initiating the treatment of patients into we're entering our 6th and 7th states in this quarter. And the scalability, we work with community providers. It's a combination of in-home hub providers that we have, and then when we go into new states, we reach the entirety of the state that we're going into. So when we come to North Carolina, we will cover the entirety of North Carolina, and we'll set up provider hubs in the different regions as we designate it. And as we have patients that live outside of our initial hubs of providers, we will work with local clinics and hospitals and local areas to source nursing and peer recovery coaching that can deliver in-person services. So the scalability is really quite good because we're utilizing remote services. We don't have the brick and mortar facilities. It makes us very flexible to need. And for us, we only operate a network. And so we do not operate out of network. So we go where our insurance contracts are. And so that's really, that is the only hold on the scale.
Great, thank you. We have another question from online. How do you prepare your clinicians for the cultural issues that are often unique to different regions? Not all rural communities are alike. Do you have certain staff that are specifically trained and knowledgeable in different regional cultures, for example, Central Appalachia, and are those staff assigned to those regions?
Yeah, so in North Carolina, which is Eleanor's biggest state, where we have 11 bricks and mortar practices, I think we have about 1,600 active community members currently. We divided the state into 3 regions, and our care teams align with those regions and tend to be based there. Many of our primary care providers who are doing the addiction medicine side practiced in these communities for several decades, and in some situations are from the communities provide care in. Our psychiatry services are spread more across the state. And in that situation, using our community recovery partners, who are often local to Wilmington or Fayetteville, to provide the local insight is critical.
Yeah, for us, we source, as I mentioned, some local providers for services where we can. So the nurses are going to be from the teams that are serving, the peer recovery coaches will be as well. Some of the translation of the cultural dynamics of the various areas that we go into are the education on those cultures will come very much from those providers as they do some of the coordination. We've tried to educate our Southern California psychiatrists on what it's like to live in an 1,800 person community. It's not, sometimes that translation is lost, but the services that are being rendered by those particular providers tend to be as highly effective there as they are in their own communities. When it comes to the peer recovery coaching, we find that it's incredibly beneficial when they're engaging with the patient on a more personal relationship level rather than clinician-patient level, to have an understanding of the community in which the patient resides. So engaging the nurse and the peer support there is very, very important.
And also hiring, creating, upstream, hiring people who are comfortable asking patients questions about where they're from, asking what a phrase meant, to sort of level that playing field. I'm still the doctor, but if I can say, I didn't quite understand what you meant by that colloquialism. Can you explain it to me differently? And just sort of opening up a little bit on mine is a benefit. Yeah, Austin.
Sounds like you both offer a combination, a hybrid of virtual and in-person services. How would you compare the value of being able to do that to a virtual only practice working with the substance use disorder? Where's the value in that? What you are able to do face to face?
Yeah, that's a really good question. And I think we've done plenty of testing of both, right? Virtual only programming as well as the combination. Some of the integral components of a patient's environment that are incredibly beneficial for our team members to be acquainted with are only gleaned when they go in residence. The nurses, as they're working through kind of nutrition protocols and giving the patients progressive tasks, right, to engage in the program and start making small improvements and adjustments in their own environment. It's very, very helpful for those providers to know what that environment is. It gives a much better understanding. I'm not a clinician, and so I don't deliver direct services. This is feedback from our providers that they have noticed a higher level of connection with the patient when they've been able to be in residence with them. There's a lot to be gained from screen to screen, but there's a percentage missing there that I think we gain being in person, right? And getting to know someone face to face. So that's how I sum that up.
On a bigger level, I think that having a bricks and mortar presence or a physical presence in a state with some of your employees adds a sense of legitimacy to your organization. It increases the trust when a family doc is making a referral to you, that they know that they can send them to the practice on 9th Street and that somebody will be there. When we look at our map of North Carolina, even though we have people spread across the state, they tend to cluster in a 30-mile radius of each of our individual practices. And so we still see that local nature to the care we provide.
Great, thank you all. So we are right at time, and appreciate both of our speakers for taking time and sharing their experiences. For those that are in person, you may see them around, but there's also the opportunity for everyone to interact via the virtual platform. So please use those networkings, those connections. You can find the speakers under the agenda part of this session. I will ask if the AV Tech can put up the slide for the information for a session evaluation. That can be found as well on the virtual event platform. And then just knowing right after this, there are some poster sessions happening and a couple of other sessions around behavioral health, data-driven healthcare, and school-based telehealth. And don't forget to participate in the virtual networking event this evening, 5:30 to 6:30. So thank you, everybody, for your time. Enjoy the rest of the conference.